My name is Scott Mash, and I would like to welcome you to today's webinar titled Balancing the Proposed Reporting Changes for 2020, which is a deep dive into the calendar year 2020 physician PPS proposed rule. And as always, I'm joined with my good friend, Miss Cathy Costello.
And if you notice in that picture, that's Scott at the bottom holding everyone else up.
That's the reason for my bad back. Now, if you are struggling with MIPS or promoting interoperability, maybe one of the new payment reform models, CPC Plus, or even any of the new emerging models, we can help you out. We do provide a consulting service that we call CliniSync Plus. We can help you on any of those programs. Just contact Cathy or me, and we can set and talk about your specific needs, and then provide you with a proposal. I'm going to turn it over to Cathy so we can get started.
Thanks, Scott. Just so you don't get worried about the number of slides, I just wanted to point out, as Scott said, there is a ton of information in this year's regulations. But what we did is, so that it would not overwhelm you, if you go back to slide 81, it's called Additional Resources, and we kind of grouped specific information about changes in quality and improvement activities and things where there's just a ton of information about little changes that are made. We put that back there for your reference, so you can quickly refer to if you're looking for a specific measure or something, but it isn't in the bulk of the slides, so it doesn't overwhelm you. But those of you who have joined us numerous times will know that usually when we start, we always start with the status of all the regulations. And unfortunately for all of us in healthcare, we are linked to a big regulatory practice. And so we kind of have to pay attention to where these things are. So this year, the top 3 regulations that are in the box are what I'd call not our repeating regular regulations, as you see on the bottom 3. The bottom 3 are the hospital inpatient rule, the hospital outpatient rule, and the physician fee schedule rule. And that's what we're talking about today. Those are repeating regulations where they are released every year, usually within just a few days of the date every year. So we usually know when they come out. This year was an exception, of course. The physician fee schedule was almost a month later getting out than it normally is. And I think some of that is due to the volume of the programs that they were trying to address. The top 3 regulations are ones that are what I call non-repeating, but very important anyway. And that's a standards rule that kind of sets, new standards for your EHR system. In interoperability and patient access rule for the payers. And then TEFCA is the new information network that they're trying to set up nationally to be able to exchange records. Of those, none of those are finalized, although TEFCA did have a coordinating group appointed last week to kind of oversee the development of that network. But the other rules, we are expecting them to be released by the end of this year, and we will be doing further webinars as those information blocking rules become public, because it's just too important an area to ignore. So kind of just pay attention over the next month or two where we head with those rules. The last rule to comment on is the one with the red arrow, and that is because it is the most recent one. And this was put out as a clarification for how you handle 42 CFR Part 2 is the technical legal term for specific drug and alcohol records. And what the law does in this area is identify how you are supposed to handle those records when you share them with another provider. And again, we're not going to go into a lot of detail today on that, but we will show it in another future webinar. And the issue here is how you are segmenting your records. But the reason that SAMHSA put this out, SAMHSA being the agency that oversees drug and alcohol for the federal government, and the reason they put it out was to clarify that primary care providers can have information about that patient's drug and alcohol treatment within their own primary care record, and that is not a breach of 42 CFR Part 2. So that's something, again, if you're in charge of handling records for your organization, you just want to be aware that there's this clarification going on in which you want to keep those records separate if you're drawing information in from a drug and alcohol treating program. But this does not prohibit your primary care practitioners from entering information into their record to coordinate the treatment of that patient. So that is where we are with all the regulations to this point in time this year. I'm sure that will change within the next 2 or 3 days. Scott and I always take bets on when this stuff's going to come out, and we'll see. But let's turn to the physician fee schedule rule, because that's really where we wanted to be today. And there certainly is a lot of information there. CMS, as you look at what, once again, was in a very extensive rule, has certain priorities that rise to the top. One of the biggest priorities, and we saw that bleeding over from last year's regulations, is they are very intent on having the business practices of both hospitals and physicians change, especially in the area of how you bill and get paid by CMS. So they wanted you to revise your billing practices. They started that last year, and we're going to look at how that changed in just a second in this year's proposed regs. The second area is care coordination. Oh my goodness. As you all know, I'm not telling you anything you don't know. No matter what program you're involved in or what you're doing, care coordination is a linchpin of that workflow. The last thing is CMS has a big push on, especially this year, for interoperability, and that is linked to the new reporting standards that came in this year under the Promoting Interoperability. What a catchy name, Promoting Interoperability. You never know what they're talking about. But we'll look at that in a few minutes when around the technical reporting. But that is a very, very high priority. And an offshoot of this, I don't have slides on this right now, but we'll probably do it in a later webinar, is you need to be aware that as part of the whole question of interoperability, CMS has just an extremely high priority on patient access to their own records. And we're going to talk about that in a few minutes relating to the development of phone apps for the patient to access that information and how much of that's required. But just recognize that the Office of Civil Rights just put out a settlement with a major academic hospital over non-access. The patient was not given access to the records within 9 months. And that hospital got fined $85,000. And there's a lot of terms in there that I think people should be aware of, but I'm just saying for you as a bottom line to make sure that you've written policies around patient access to their information and then that you follow those policies. Okay, let's start with the business side of things. The E&M coding, which as you all know, is near and dear to everybody's hearts because it sets how you're going to be paid and how much you're going to be paid. This was addressed in last year's rules, and all I can say is it was very, very, very interesting to see the difference between last year's rules and this year's rules. Because last year you had a very specific, CMS was putting out a proposal, and actually they finalized it, to change the 5 levels of E&M coding for physician office visit payments, which were linked to the level of complexity of the patient. And they after much debate, collapsed that into basically 3 levels of coding, and they were going to change the payment and on and on and on. It was very complex what they were doing, and that was to go into effect on January 1st of 2021. Well, in this year's regs, here you are thinking that was final and that you better be getting educated around that. This year opened the regs only to discover that CMS all but said, "Oops, we made a mistake," because what happened was the AMA stepped in, and for those of you who do coding, you recognize that the AMA is the owner of the CPT codebook. And so every time you access that online, you have to click that you are, using it appropriately, and it's all back to AMA. So the fact is that AMA stepped in sometime between that reg was finalized last year and these proposed regs came out and said, we don't think this is the best way to change the billing for physician office visits. And historically, the last time there was a major change in how you billed for physician office visits was back in like 1997. It's been a while since that code book's been updated. So it is pretty out of date, requires a lot of labor-intensive work, but for whatever reason, that was not coordinated before, changes were not coordinated before the rule came out last year. So this year, CMS basically says we are taking back everything that we proposed in last year's regulations, and instead, at this point in time, they're adopting pretty much everything that AMA came to them with. And what AMA came to them with is AMA's apparently, based upon all their business acumen around physician offices, had tons and tons and tons of data by specialty as to how much time it took a given specialty to do testing, see the patient, both pre and post visit. I mean, it's very detailed, down to the RVU units that were going to be necessary to bill them at a appropriate level. And AMA put this forth and said, we think that you should go back to the 5 levels of coding, level 1, 2, 3, 4, and 5, that reflect the complexity of the patient's case. But what we are suggesting is, rather than just bill as you normally do, give another option, because right now you can either bill according to medical decision making, how complex the doctor feels the patient's care is. You can bill according to one of those old CPT books that I said, 1995, 1997. And now this year, based upon what AMA and CMS arrived at, is a third way of billing. And this is by time. And you will see the concept of billing by time laced through all of CMS's policies this year in how you get billed and paid for not just the physician, but for the office staff. And so if you are working with an EHR system for a given practice, you are going to want to be considering this. You don't have to have, your practice does not have to change the way they are billing to link their billing to time, how long they see the patient. But if you do, you're going to want to understand how that is documented within your EHR system. So billing by time is a major message in these rules. And so what you're seeing on this slide is the change in billing procedure is still going to be linked to January 1st of 2021. So not this January, but the following January. It will affect all Medicare Part B E&M claims. And I'm sure many of you have already been either starting to get into some of the training that's going on around this, or you've seen what the AMA has online. when this is finalized later this year, what I would highly recommend is that you make sure that your staff and anybody involved with coding lines up for next year education programs for how these new coding changes can take place. I mean, there were other changes, but that was the biggest message I can give you, is that time is linked to how the physician can be paid. The second part of this, and this was in a different regulation, is for those of you who work for hospital systems that might use facility fees for your physician office visits, that is based upon last year's regulation, that was being done away with. And the only reason I'm pointing that out to you is because the CMS Advisory Committee for the hospital rule has recommended that they freeze that cutback of the facility fee. And so we'll just have to see in the final rule if in fact CMS does choose to freeze that. Here are the various points that were made in the proposed changes to the E&M coding. As I said, returns to the 5 levels that you are familiar with now. Documents according to time, although you can use the older standards if you want. And then makes 2 changes to allow you to bill for patient complexity and for prolonged visit code. Now, let's look at care management, because again, this is linked to how CMS perceives how they're paying your practice. So right now, we just talked about how a physician is billed for the time that they spend with the patient. In care management, for the most part, although there are some physician codes, for the most part, you're looking at billing for what your staff does to promote chronic care management or care management across different groups with the patient in a non-face-to-face setting. What I'd say is there are many, it's gotten very crowded in the definition section for care management. I'm sure all of you who work in this area feel the same way. It's like, oh my gosh, here comes another code. Here comes another specific area. What CMS is trying to do is to pigeonhole all these programs that support a coordination of care management, and to allow your staff to get paid for time that they spend on the phone, you know, with specialists, talking to the patient about what needs to be done, whatever it is. They are driving these care management programs to allow you to get paid for additional time for your staff. But the problem is they've gotten really, really complex as to how they're listing all these codes. So here's kind of a quick and dirty summary, but it does not include all the codes or all the care management, because, for example, there was a whole set of codes put in last year around behavioral health care management, and those are listed separately. But the biggest ones are transitional care management. That is care management that is done after a patient is discharged from a hospital, but can also include discharge from any of these other sites on the right-hand side. So it can be from nursing homes, rehab, behavioral health, long-term care hospitals. So look through that and think about it if you have providers who are providing services at one of those locations. Under chronic care management, so transitional care is acute, short-term, billed around a certain number of days after that person is discharged. Chronic care management is more of a longitudinal management of patients who are ill with a variety of chronic conditions. And this gets tricky because chronic care management requires that you be treating a patient who has at least 2 problems that are identified as chronic conditions. And those can be considered complex or non-complex. And so remember what we were talking about just a few minutes ago about time? When you look down this chart, a lot of it has to do with time. How long does it take you to work with a given patient in that month may dictate how you end up billing for that patient. But the reality for chronic care management, or CCM, is if the patient's considered complex, then the time that's linked to you being able to bill for that care management is 60 minutes with additional add-on time of 30 minutes. For the non-complex patients, so just routine care management, say with diabetes or hypertension or whatever, it's done now. The proposal is the current payment mechanism is 20 minutes a month, or 20 minutes of billing period. What they're talking about is dropping the add-on to an additional 20 minutes. So it'd be 2020. There is, we'll look at these next two in the next slide. Principal care management, difference here is one chronic condition, and we'll look to see how that's being done. And OUD is for opiate use disordered, and this is time dependent, but it is also a bundled payment. Care management, the reason CMS has really pushed care management in actually the past several years in the regs is they feel that Medicare patients could be better handled if there is better coordinated care. But what they're seeing as these claims come in for CCM, TCM, or whatever, is they're not being widely used. Less than 10% of all the eligible patients are receiving some type of coordinated care management. So this is why you see them refining these codes to hopefully make it easier for practices to go ahead and bill for them. Another change they made, because in the care management area, one of the reasons they were getting feedback in from focus groups on why people weren't using it is that, for those of you who started with chronic care management back several years ago, you know what I'm talking about, is there was a requirement that you actually had a written document that showed that you had some type of contractual arrangement with an outside service to provide care, and you had to have a specific name of somebody who was going to provide it and everything. And people are like, no, that isn't how it works. When you're out there trying to coordinate care for food or housing or specialists or whatever, frequently you don't know the name of who that person is, or that person changes, or whatever it is. And so CMS took pity on everyone who works in this area and has now changed it from the requirement that you had to identify the individual responsible for the care or for the coordination in another agency or specialty, to the phrase interaction and coordination with outside resources and practitioners and providers. So it's much more general, much easier to work on, does not require you to update your list every week as to who you're coordinating with. So what that does, by putting that change in, this is these are the fields that a comprehensive care plan would have, and with the updated language around interaction and coordination. Now, for opiate use, again, there had to have been at least 50, maybe more pages in the regulations around setting up opiate use disorder programs. So if this is an area that you're interested in, there is going to be a lot of information out there. But just a couple of very high-level points I'd make here is, effective July 1st of this year, Medicaid will now pay for substance use disorder telehealth visits from a patient's home. You do not have to have the originating site does not have to be part of a healthcare institution or covered entity or anything. You can actually bill for services where you are setting up and you are dealing with the patient in their home environment. So if that's an area that you're interested in, watch as those regulations become final so that you understand what the requirements are. The other thing I'd say is CMS has not heretofore paid for medication-assisted therapy in the outpatient area. It's been inpatient, has a lot of requirements around it, and on and on. Well, as a result of the opiate problem, they are bending a lot of the what has heretofore been very structured rules and trying to make these more usable. And this is one area that is changing. And what they are saying is that they are going to start paying for medication-assisted therapy, outpatient treatment, but the caveat here is you have to be SAMHSA certified. So you have to receive that federal certification in order to bill CMS for those services. And because there's such a need, and for those of you who work in this area, you know what I'm talking about. There's been probably 1,000% increase in the past 2 years on medication-assisted therapy sites. And so CMS is actually putting in a new place of service code just for these outpatient therapy programs. Transitional care management, back to what we were saying about transitional care management and chronic care management being billed at a lower than anticipated rate. One of the reasons that transitional care management was not always billed when it could have been is that there were all these exclusions. Oh my gosh, it was just crazy. You could bill transitional care management, but you couldn't bill chronic care management within the same calendar month. And you know, if you billed it halfway through the month, you had to finish the billing by the end of the month. It was just really crazy. So one of the things that CMS did not allow in the past was you to bill the same, more than one care management code in the same month. So they are proposing to do away with this requirement, and they are talking about, in these cases, in these, the ones listed here, you can bill them at the same time that you're billing transitional care management. So if you have a patient coming out of the hospital and you're working with them and you have, for example, you're doing end-stage renal disease, or back here on this next page, the complex chronic care management. So you're dealing with a patient who's quite ill, that you can bill for both transitional and chronic care management. What you do not see is the overlap. You are still not allowed to bill for non-complex chronic care management at the same time as transitional care. So you just kind of, as these rules become final, look to see if you're doing a care management program, just make sure that you're reviewing what the changes in those billing codes might be. For non-complex services, as we mentioned, the CMS is trying to simplify how they're handling all the care management, and basically they're creating time categories for every care management program. So you have your initial billing and then an add-on based upon the number of minutes that they think is reasonable as a block of time. So in the non-complex chronic care management, so the one that we usually work with or consider working with, they are going to create two codes, one being initially 20 minutes, which exists now, but the add-on is also going to be 20 minutes. It had been a higher amount before, so this is to make it more usable for those of you who deal in this area. For complex services, so a sicker patient where you have to spend more time on them, you want to have, you're going to end up spending as much as 60 minutes with that patient during the month. And so 60 is the base amount and 30 is the add-on amount. There is a new care management code, and this I do think would be of interest to everyone, because as we all know, when you get into these complex situations, you may frequently have a patient who has, who has more than one condition. And an example that I can think of is you might have a patient with diabetes and hypertension who also has a cardiac situation going on. In this case, the primary care may want to handle the diabetes and hypertension controlling what they're getting as far as care management services, but they may want to have a cardiologist actually do monitoring of the cardiac situation. And so they have created a new code around this called Principal Care Management, so PCM. And this is for only one condition. So you don't have that requirement of 2 conditions, but only one. And the interesting thing about this is the billing is not limited to specialists. So it could be billed out by a primary care also if you have a specifically identifiable condition that requires that constant monitoring. And the other thing that is worth noting with this PCM billing is you can have more than one provider bill for principal care management in the same month. So if you have a patient who, for example, as I said, it could be chronic care or be diabetes and hypertension, you're monitoring that at the primary care level. You can have a cardiologist doing the cardiac monitoring, but you may have a GI because that person has, irritable bowel syndrome or something. So there are different ways that chronic care management can be billed. Depending on the patient, what I'd say is look at 2 things. One is, what is the condition of the patient? What are the conditions you are trying to monitor? And then how much time does it take? And those 2 should decide on how you would bill out these services. Okay, and these are just the new codes. And for principal care management, the one that is the more specialized care, the time that they're looking at is 30 minutes initial, 30 minutes additional. So with that, let's turn over to MIPS and Medicaid and get back to our usual familiar areas. Since everyone loves to talk about billing, it's so much fun. As I said, make sure you've got an expert coder and biller that can work with you in the coming year as these changes become finalized. For MIPS, just to review where we are this year, 2019 is 2021 billing. You've got a plus or minus 7% penalty or potential incentive. For this year, starting next year, it is 9%. So it's really important that you understand how the program is shaping up. And this is already in law. So we already know that next year and in 2021 that there is going to be a 9% penalty if you are not successfully reporting your providers for MIPS. The weighting within the program of the 4 categories, promoting interoperability, which is your technical, quality, improvement, and cost, keeps shifting over the next few years until it gets into what I call the groove that Congress has decided overall. So last year we had promoting interoperability is always going to be 25%, and if you're not in a special or in an APM, it's always going to be 25% because Congress wants to make sure that people are reporting on their technology. Quality and cost are the 2 that are going to change. Improvement activities are going to stay at 15%. So quality, which had really been a large part of your MIPS reporting from the beginning of the program, is going to continue to drop, and cost is going to continue to rise as part of your score, so that each one of them within 2 years is 30% of your overall score. So you have to pay attention to both quality and cost over the next few years. The thing that Scott and I are really upset about, we looked at this and we were like, oh my gosh.
Yeah, it kind of gets me a little bit, the first one.
Yeah, and this again is all proposed. It could be changed in the final rule, but I'm telling you, because if any of you have copious free time and want to send a comment to CMS, you may want to comment on this one. And that is the amount of points that you need to get in MIPS to avoid a penalty. And what we're talking about, I think most of you have worked with it enough years now that you know, but there's 100 points potentially in MIPS. And when we started the program, if you scored just 3 points, you were going to avoid penalty. And then if you scored 30 points, you were going to avoid penalty.
15 the second
15,
year,
30.
Yeah.
And next year in 2020, it would be 45 points. And in 2021, it would be 65 points.
The interesting thing about the 65 points is in the first year of the program, an exceptional performer was 70. So you go from a swing from where you could have been maybe not a high performer, but a good performer, to now getting a 9% penalty.
Right. So we're a little bit concerned about that, and we are going to comment on that. If any of you have anything we can use as evidence when we comment, we'd be more than happy to have it. But the reason we're concerned, truthfully, is we have dealt over the past several years with quite a few groups who have changed EHR systems in the middle of the year. And this is always tricky what to do. I mean, other than obviously you can take a hardship, but if you're trying to score and trying to establish a history, you really have to take into account how long you need to report out of one system to get your quality metrics. And this is why it was helpful when it was a lower score and the weighting was different.
Yeah, because for example, in that 2021 reporting year where you've got to get 65 points, if you switch EHRs, yes, you can file a hardship. The hardship only covers you for PI and it reweights quality. We had a couple issues this past year with EHR vendors that for some reason couldn't report quality. And in 2021, if you don't report quality, that's 35 points. And now you've got to get 100% in all other categories to avoid penalty. And so we see that as the downside and where we're going to make our comments back.
Yeah, and then the exceptional performance category continues to rise, and we think this is because CMS is trying to spread too few dollars across fewer number of providers, so that as that exceptional performance moves up into the above 80 category, you're really looking at a drop off on the number of people who are considered exceptional performers.
And that's part of the reason for the raising the minimum as well, so there are more dollars to spread around to the high performers, but it's the wrong way to do it.
Yes, true. The proposed rules continues the recognition of complex patient bonus, and this is the additional scoring that you receive, points that you receive, if your patients overall as a group are showing medical complexity. And CMS defines this as either through the HCC risk scoring or through the Medicare-Medicaid dual eligible status, because that is traditionally linked to patients who have greater health needs. The facility-based scoring is definitely going to continue on. It's clarified this for those of you who have not used this. Facility-based scoring is scoring where physicians who do 75% or more of their billing in the hospital setting, rather than reporting, can use the hospital's quality reporting under value-based purchasing to meet their MIPS requirement. The clarification that CMS did in this year's regulation is basically to make sure that you are counting on it being a hospital that participates in value-based purchasing. So VBP, value-based purchasing, is not traditionally a program that, for example, CH hospitals participate in. So if you are planning to use facility-based scoring for any of your providers, you just need to make sure that your hospital is participating in that program. Auditing. Audits have started again. I know this is something that you all wanted to hear since Bigliosi seems to be a thing of the past. We kept waiting for a new Bigliosi letter, but it's a group called Guidehouse. I have no idea if they have any relationship to Bigliosi, but do expect to see audits. I know this is proposed rules, but the reality is we had heard this already.
Yeah, CMS had released a news release that said the audits have started. They've already sent out some audit notifications, but if you've received one, please send it over to us and we'll see if we can help you out.
Yeah, and the Ohio Medicaid audits are also underway, and that is run separately, and it comes through the state auditor's office. Medicaid. We're getting into closing in on the end of the Medicaid program for those of you who are still participating in the EHR incentive program with Medicaid. The program technically shuts down in 2021, but they're going to have some tailing off of some of the programs to allow the state Medicaid programs to report back to CMS by the end of 2021. So what our Medicaid program is saying, you still need to have your ECQMs report a high priority or outcome measure, and technically the program ends on October 1st of 2021. So you are being directed that ECQMs must have at least a 75% or 9 months worth of data, and the security review needs to be completed by the end of the calendar year. In Ohio, it does not need to be completed by October 1st in 2021, but instead by the end of the year. And again, this is 2021. This is not next year. There's still a full year next year. Okay, and with that, we're going to look at the specifics in the MIPS program.
All right, so now we're going to focus on the promoting interoperability category within MIPS for a few slides. And the good thing is there's really not a lot of changes here in promoting interoperability, not anything big, but the category weight's going to remain at 25% for the foreseeable future. One change that is being proposed is CMS did not receive a lot of data for the provider types that have been added to MIPS over the last couple years, your PAs, NPs, OT, PT, any type of clinician that has been added within the last 2 years will remain with the ability to reweight promoting interoperability to 0. CMS still needs a few years to determine how those provider types are reporting. The downside from a CMS standpoint for having the ability to analyze those provider types is most folks now report as a group, so they can't see specifics around those provider types. But at any rate, they stay with promoting interoperability weighted to 0. Also, another clarification that CMS tweaked was for the hospital-based or non-patient-facing groups will be determined to have that status if at least 75% of the providers within the group are deemed hospital-based or non-patient-facing. In the past, all providers in the group had to be hospital-based or patient-facing for the group to be also, but they've kind of backed off a little bit and allowed a little bit of leeway with only 75% of those. CMS has also revised the exclusion language to the new HIE measure, the Support Electronic Referral Loops by Receiving and Incorporating Health Information. You know, we've had the exclusion that allowed for you to not report on this measure if you were having technical issues. Now they've added the exclusion language like we've seen with the other HIE measure, that if you receive less than 100 transitions of care or new patients, then you can exclude from this measure. If you exclude from one HIE measure, then the 20 points goes to the other HIE measure, making it worth 40 points. If you exclude from both HIE measures, which is technically possible, then all 40 points go to your portal measure, making it now worth 80 points. So our suggestion for all groups, that's a 40-point measure, that patient portal. So really focus on that this year to improve your score. Now, some other little tweaks to promoting interoperability is that the EPCS, or the electronic prescribing of controlled substances, will be required in 2020. It is technically, it's an option for this year, but it's going to be required in 2020.
I think they may even be pushing that out one more year. So
yeah,
we're going to have to see in the final what that looks like.
Right. The ORS integration, or the PDMP query, they are allowing for a web-based query in 2019, or a query in any manner allowed by your state, and that would give you credit for the PDMP query. The opioid treatment agreement query, CMS has readily said, hey, we got the cart way out in front of the horse, so it's going to remain an optional bonus measure in 2019. Then next year it goes away completely, not even a measure in the program anymore. Again, with the HIE measure, you can exclude from both measures the new measure can be excluded if you're having technical issues. But on that receive and reconcile measure, you must reconcile your drugs, allergies, and problems within the EHR system. That reconciliation process can be it's all duplicate. We want nothing or we want everything. So just focus on that reconciliation process within your system. Now, the APIs are still proposed to be part of your provider to patient exchange. And we're going to talk a little bit more about the APIs here in just a few slides. So looking forward to next year, the 2020 reporting year, this is how your scoring is going to be. You can see here that the Verify Opioid Treatment Agreement is gone. You have the PDMP bonus at 5 points. All the scoring looks pretty much what we've seen for this year or for the 2019 year. No big changes for scoring. So now we're going to talk a little bit more about APIs.
APIs are basically the technical connection that allows you, among other things, to have phone apps connect to your system to get patient data. CMS views this as their answer to patients having access to data because they think that these phone apps can take data from a hospital system, from a physician system, from a payer system, and combine it all into one consolidated record in the patient's phone. You know, technically, we're there, but we're not there with all these phone apps. And CMS actually says in the rule that they may be having certification of these phone apps. And if they do that, it may actually be another 2 years before the program is fully recognized. But as Scott said, because we're having to deal with last year's rules, it still is on the books that you're supposed to have information available through a phone app for your patient.
Yeah, and really there hasn't been a lot of vendors that have jumped on this bandwagon yet. Some of the EHR vendors, of course, are developing an app.
Epic and Allscripts,
yeah, but to see the small developers or the up-and-coming developers, we really haven't seen a lot out there yet.
Yeah, and the reason they want to do this is that the way that you're getting information now through the patient portal is through what is called CCD, the Continuity of Care document, which is just that, a document for the whole encounter. And CMS wants to back this up and have it become discrete bits of data that can be reassembled in the phone app. And so we're just going to, again, we're going to have to see what CMS does with the certification requirement that they're talking about for these phone apps. But if you are planning to report on use of phone app this year, which until the reg changes you would have to do make sure that you have a written policy about how phone apps are going to be connected to your system, what your identification process is for the patient. And what we're actually recommending to groups is they also have a written policy around the patient portal. So it'd be the two sides of the patient access to data. That'd be either through the portal or the API, that you explain that if you have an internal group, either at your practice or at your organization that oversees EHR development issues, state in that regulation if you're having that reviewed by that group. So I would strongly recommend this because that's one of the things, if you think way back to the beginning when we were starting this webinar and we were talking about the Office of Civil Rights reaching a settlement agreement with that hospital in Florida, one of the things that they required is that the hospital develop a set of policies around patient access to their records. This is the timeline as we know it right now for the API development. It's still in the reg for this year. They had wanted the payers to also make their data available through APIs in 2020. And then in a separate non-final reg, one of those ones at the top of the chart at the beginning, hasn't been finalized yet, but they're talking about this 24-month program rollout for APIs generally. So we'll see. We'll see in the final regs how this all shakes out, but just wanted you to know that they're still in the regs right now.
So now we're going to turn our focus over to the quality category within MIPS. Now, as the cost category goes up, the quality category weighting goes down, and we're going to see it's going to drop 5 points a year because that's what cost is going to increase over the next 3 years. For this year, we've had a data completeness rule of 60%. That goes up to 70%. And what that means is when you submit an ECQM, let's say for diabetes, the A1C, the denominator for that measure should include at least 70% of the patients with that condition in the denominator. You got to get at least 70. So if you don't meet that data completeness, you will actually receive a score of, I believe, 0 on that measure. And the way they determine that is they look at the claims to see how many patients in your practice you have with a condition based on problems that were assessed assessed on a claim form. The bonus for the end-to-end reporting and bonus for additional high priority or outcome measures remains in 2020. We don't know if that's going to go away in 2021 yet. And the bonus for improving your quality score remains for 2020. Now, keep in mind that this improvement focuses on your overall quality score, not improvement from year to year on a single ECQM, but it's your overall quality score. Oh, yep, here we go. The measures that don't meet the data completeness requirement are given a score of 0. They are maintaining the 3-point minimum score for quality measures, meaning that the lowest score you can receive is a decile 3. If you drop below decile 3, you receive a 0 score for that quality measure. Measures that are submitted that don't meet data completeness but don't have a benchmark, you can get 3 points for those measures as well. And every now and then CMS will tweak a numerator, denominator, or an exclusion, which then requires them to reset a benchmark. You're always going to get at least 3 points for those. Now this is one that's kind of a little bit odd, but CMS is proposing for certain measures that have, quote unquote, the potential to result in inappropriate treatment to away from the decile. They want to switch these away from the decile scoring, but instead go with what they're calling a flat percentage scoring. So above a 90%, you get 10 points. From 80 to 90, you get 9 points, and so on. And
for those of you who've been doing this for a long time, think back to PQRS and stuff, where you had a set benchmark and there wasn't all those various forms of reporting and stuff. And I think that's where they're heading back, is just to make it easier for people to understand.
Yeah, and they call out 2 measures specifically, and it's the diabetes A1C, poor control, and controlling high blood pressure. These measures are in every single payment reform program and ones that Cathy and I focus on a lot. Now, the way this would work is this is an actual example of these 2 measures and what CMS is proposing. The top shows the current scoring methodology based on deciles that they come up from the historic review of benchmarks. So, for example, with the A1C poor control, if you want to get into the 10th decile, this is a reverse measure, you have to get a score lower than 14.71. Well, under the new program, where we go to flat percentages, the highest category or the highest score would be the top 10%. So if your score is less than 10% for the A1C, then you would be in the highest scoring decile. And controlling high blood pressure being not an inverse measure, but one of our regular measures, if you would get a score higher than 90, then you would receive 10 points under this new program. So it just kind of flattens things out, makes it a little easier to understand, and this will be interesting to see if they move forward, because it does have a little bit of an impact on your scores if you're up towards the upper end. It makes it a little easier at the lower end as well. Now, some other changes that are being proposed, they're adding 5 measures, removing 55, and modifying 78. And again, these are just proposed numbers right now, but we would like to look at the new quality measures that are being added, because they actually have an impact on what's being removed. See the first measure, adult immunization status. Put a little star next to that one because we're gonna see how this one, actually this one, the way it impacts is on the removed measures. It's replacing the pneumococcal, flu, and the Zoster's shingle virus. So it's combining this into one measure. The multimodal pain management, CMS is making a lot of tweaks to anything that's around pain management or pain assessments because of the opioid crisis. But again, these are the 4 measures that are being proposed to be added in 2020. The one that's really interesting to me is out in 2021, CMS is proposing adding this all-cause unplanned admissions for patients with multiple chronic conditions. The way they're wanting to add this is, if you think back to this most recent reporting year, if you were in a group of a certain size, you could have a 7th quality measure added that looked at readmissions. This is going to work the same way. So now you could have an 8th quality measure automatically added that looks at unplanned admissions. So not only is it readmissions, but sorry, I'm going to get to my notes here. So you're going to have readmissions and preventable admissions now as part of your quality score. So be interesting to see how this one plays out and if it makes it to the final rule. Now for the measures being removed, again, 55 measures are proposed for removal. We went through the list. These are the ones that we feel are the most common measures out of that long list of 55. Not that there aren't others in there that your organization may be reporting on. It's just these ones we see all the time. And you see here we have flu, we have the Zoster's shingles virus. Now these depression screenings that we see being removed, that's to get rid of some duplication because there must be 15 different depression measures.
Right, and that's what I would say is, if you're working with any of these measures, don't assume that they're just disappearing. It's usually that there's another measure that's more comprehensive. For example, the functional status assessment, there's a broader measure that's been brought in that covers more than just dementia. Depression, some of the depression screening, there's changes related to exclusions that are being set up in other measures that are being maintained. So just if you see something that you're used to working with and you're concerned about whether you can still report on it, look through the new measures section and you'll see that it'll probably show up elsewhere.
Yeah, and the list of all measures that are being removed and modified, you'll find at the end of the slide deck when you download it in the additional resources section. So now measures with changes. There are 78 measures within the program that have been modified in some way. These are the ones that we see most commonly. You see at the top of that list, A1C poor control. And the big change there is CMS updated the exclusions to include patients who are 66 years or older with advanced illness or that were in a long-term care facility for more than 90 days during the reporting period. They apply that same exclusion language to the colorectal exam, to the breast cancer screening, to, you know, that exclusion language has been added to many of the measures that appear on this screen here. Let's see, like the high risk medications in the elderly, CMS updated the numerator statement there. For the BMI measure, they updated the exclusions to include patients in hospice care. So just some minor tweaks to exclude patients that are nearing end of life or are in a setting where the primary care provider doesn't have that high touch with the patient. So again, the full list is available in the additional resources section of the posted slide deck. Now we're going to look at the improvement activity category. No change in weighting. The big change I see here is that when you selected an improvement activity in the past, you could select it based on what one clinician was doing within the group. And now CMS is modifying that so that the activity has to apply to at least 50% of the clinicians comprising the group. Also, they're just got some clarifying language saying that the group must perform that activity for the same 90-day period, or at least the same 90-day period. And again, there were some measures that were tweaked. We have 2 new activities, 15 that are going to be removed, 7 that are going to be modified. The removed and modified measures you can find at the end of this slide deck, but we're going to look at the 2 new improvement activities. First one being drug cost transparency, and the second one is really the use or reporting of the MACRA patient relationship code. So we don't see a lot of new improvement activities, but this drug cost transparency is one that some of you may want to use for your improvement activity in the 2020 reporting year. Now we're going to look at the cost category. Quality is going down in weight, cost is going up in weight until we see in 2022 where cost and quality become the same weight within the program. CMS is modifying the attribution and risk scoring methodologies for both the TPCC and the MSPB cost measures. CMS has also made the decision to add 10 additional episode-based measures.
So total cost of care and Medicare spending per beneficiary, which is a episode-based measure.
Right.
Those are the 2 cost figures that we're working with.
Right. Well, actually, there's 3, because the way CMS is working this is if let's say you have enough episodes to where you have at least 1 episode category, then that would make within the cost category total cost of care, spending per beneficiary, and episodes weighted the same. If you're let's say you only receive TPCC in the episodes, then those would be weighted the same within the category. Now, the 10 proposed episodes that are going to be added in 2020 appear here on this screen. You'll see 1, the lower gastrointestinal hemorrhage, is only available to those that are reporting as a group. If you're reporting individual, you will never see that episode. Now, also keep in mind that in 2019, CMS has already added episodes. This appeared in last year's proposed rule was finalized. So we're already going to see some episodes that you are going to be judged on for the 2019 year. Then in 2020, they add some more just to make that episode list a lot longer. So now I'm going to turn it back over to Ms. Cathy.
Okay, just a few cleanup items before we go to questions. On the Medicare shared savings and APMs, there is a real move on CMS's part to align the quality metrics for MSSP with MIPS, because as you know, to this point in time, the shared savings was always reported through the web interface and had its own scoring based upon the weighting of each measure. CMS is looking at basically although you would still report through the web interface, they would like to use the MIPS scoring to score for the APMs also. So if you have any thoughts on that or problems with that, you might want to drop a line. The comments are open for another, I think, week or so. The changes in the actual quality metrics, the flu immunization is, like MIPS, is going to be replaced with the adult immunization status. And the tobacco use screening is modified, but CMS feels they have enough data historically that they can actually have the groups go ahead and start reporting on that. And the ambulatory care sensitive conditions that Scott had talked about, the admissions for those are going to be tracked only for pneumonia and UTI. So for the one of the more interesting parts of the rule is CMS is proposing, they're starting to tell us what they're going to do starting in 2022, which is the first year of a new program post MIPS. So phase 1 was getting rid of the old penalties and PQRS program and stuff. Phase 2, which we've been under now for the past 3 years, is the MIPS program. And phase 3, which is scheduled to begin in 2022, they are tentatively calling the MVP, MIPS Value Pathway. What I would say, and please pay attention to this particular point because CMS needs a lot of guidance in this area, is what CMS is planning on doing is to take the MIPS program as we know it, the quality cost improvement factors, and kind of mush them into one area and then judge providers similar to what they're doing with hospitals, where the hospitals are being judged by like types of hospitals. On the physician side, it would be like types of physicians. So what they're thinking of doing is creating categories of reporting that would include both your quality and your improvement activity. And if you're, say, in OB, you'd have to report this particular metrics. If you're in internal medicine, you'd report this type of metrics. If you're family practice, you would do this. You know, so they would have sets of these MVP reporting tools that you would be required to use so that when you get scored, you're scored against people who are practicing in your specialty. However, think about that. How many practices are designed for just a single specialty these days? So you have multi-specialty groups, and CMS basically said, hey, we're looking for suggestions as to what to do for multi-specialty groups. Should we require them to report under more than one MVP? Or should we give them their choice of what to do? You know, so this is a fast-moving area, and if you have strong feelings about how your program is going to look in 2 years and problems with reporting for it, I would definitely consider commenting on this. I don't know that there's a good answer, but
I don't think there is either.
I mean, Scott and I have thrown this around, and I have no idea what the answer is for multi-specialty groups, and whether or not it's a good idea to break every single specialty down into component parts. We'll just have to see.
And CMS readily says, we don't know what we're doing here.
Yeah,
tell us how to do this.
Tell us. So then this is a non-MIPS requirement starting next year, and this is a technical one. It's called AUC appropriate use criteria. So
and we're going to go through this real quick just to save some time so we have enough time for questions. But what this is if when ordering a high dollar diagnostic study, this new requirement or this new technology or functionality will take that order, look at the information available within the EHR for that particular patient, run that information through a clinical decision support mechanism to determine if the study is appropriate or not based on the information within the EHR. Where you have to run this clinical decision support tool is in your physician offices, outpatient departments of the hospital, in the ED for non-emergent patients and ASCs. If you're in the inpatient setting or you have an emergent patient in ED, or if you just have a hardship, you do not have to run this tool. This has been established, gosh, it first appeared back in 2016. CMS has been making little tweaks along the way, booted it back as far as they can by regulation, so that it is required starting in January 1st of 2020, though they call it a testing year. So if all the codes don't appear on the claim form, everybody's going to get paid. But starting on 2021, that's the real start of the program where claims can be denied for missing information on the claim form. Also, CMS realizes that the providers are pretty overwhelmed as it is, so a member of the care team can run the information through the support engine and talk to the physician if it does come back that it's deemed inappropriate, to provide a chance to change that order. These are the areas of focus, which again, it's all the high dollar studies. These are the specific CPT codes for the studies for which the AUC must be run. These are the HCPCS modifiers that must appear on the same line as of the CPT code on the claim form. These just specify if the rendering provider and reading provider received the AUC information, or if it was deemed appropriate or non-appropriate, but there must be a HCPCS modifier with every CPT code. These are the G codes that appear on a separate line, which really just specify the vendor who wrote the CDSM, or the Clinical Decision Support Mechanism rules. Physician compare, we always just want to keep in mind that hospital care compare, physician compare, CMS is posting more and more information out there to the public. They're proposing to share more information from MIPS year 2, some performance scores, your final performance score if you're in an ACO, but always keep in mind what you report, because it could appear on physician compare. Sometimes that bonus point just isn't worth it if it may show up here. So just a little bit of gamesmanship in your reporting. Again, keep us in mind if you are struggling, you do need help with MIPS. Cathy and I can come up with a proposal and help you out. But now we're going to also, before we get started, don't forget to sign up for the CliniSync newsletter. This is the section of additional resources which we're going to speed through. You can see there's a lot of charts, a lot of information available within these downloaded slides. Now we're going to open it up to questions. And Cathy, our first question is, can I do PCM if I am a family practitioner rather than a specialist?
Yes, this is that new primary chronic care management, and what anyone can bill for it. It just requires one chronic condition rather than 2. And as I mentioned, it can also be billed at the same time as transitional care management or chronic care management in the sense of 2 standard non-complex chronic care management. So if you've got all that, you're a better person than we are.
Yeah. Second question we got is, you mentioned hardships earlier in your presentation. If we're switching EHRs and we file for a hardship, are we exempt from all MIPS reporting? And the answer is no.
If you file for a hardship.
If you file for a hardship, that only reweights promoting interoperability to 0, but you're still required under MIPS to report quality, to report your improvement activities, and to be judged by cost.
Yeah, so it is important that you pay attention because of the increasing requirement for how many points you need in order to successfully report, that if you feel you are not going to be able to meet the EHR reporting requirements, that you get that hardship so it reweights and you don't lose all those points.
That is the last question.
Okay.
So.
Well, thank you all for joining us, and if you have anything come up, please just let us know. And good luck with that. Watch for the final rules.
Have a great day.